looking at my presentation. So yeah.
Okay. So Parchoda has joined, Saurav. So if you
Hello.
can see Professor Partha Majumdar.
I
Parchoda,
can
Saurav
see you.
is.
I can see
Yeah,
you.
but I can't turn on my. Can you hear me?
Yes,
Yes.
Prathada, I can hear you.
I
I
can't
can
turn
hear
on
you.
my camera for whatever reason.
That's fine. Yeah, thanks
But
for
that's
joining.
fine. Yeah, right.
Yeah, yeah, thanks for joining.
I think we are live now.
Okay.
Okay.
So,
So Alpana,
good evening. Yeah, I'll start. Good evening, everyone. Welcome to our next seminar in the series Human Genomics in Human Health and Wellbeing. So we have started this series as a part of Azadi Ka Amrit Mahotsav, and we welcome you all to this next seminar. To introduce our speaker for today, I would like to invite Professor Arinda Moitro, our officiating director.
Thank you, Alpana. I will just give a brief background of Dr. Saurav Guha in case you or some of our or part of members of the audience do not know about him. Dr. Saurav Guha has done his PhD from Kolkata actually. He did it from the CFSL, the Central Forensic Science Lab in Kolkata, and then he moved on to his postdoc. He did his postdoc with famous personalities. One is late Professor Ranajit Chakraborty at the University of Cincinnati Medical Center, Ohio, and then in molecular genetics with Dr. Wendy Chung at the Columbia University Medical Center, New York. He then completed his ABMGG clinical fellowship from the Icahn School of Medicine, Mount Sinai, New York. His research interest is always centered on uncovering the complexity of the genome and its clinical interpretation to enhance patient management. He also serves, in addition to who is being a ABMGG board certified clinical molecular geneticist and a fellow of the board. He a fellow American College of Medical Genetics and Genomics. He serves as the director of molecular diagnostics at New York Genome Center, and that's his present designation. And he also serves in several American College of Medical Genetics and Genomics committees like Laboratory Quality Assurance, Molecular Quality Assurance, Systematic Evidence Review Committee for Advanced Paternal Age and Prenatal Outcome, and Chair of Carrier Screening Technical Guideline Committee. I know sort of during his PhD days in CFSL, and so when we were chatting some days ago, a month or so ago, on various online I don't remember exactly, it was WhatsApp or Facebook Messenger, probably Facebook Messenger. Then he kindly accepted this offer to host his talk in our platform. So it would be great and particularly very interesting for the students community to listen to him. And we hope that in very near future, while he is visiting India, we'll be able to host him in an IBMG for a more personal interaction. So Dr. Saurav Guha, please go ahead.
Yeah, thank you, Ananda. Thanks for the invitation. And I feel like this is an awesome opportunity to interact with the students, particularly with the PhD students, which I feel eventually would probably get to this same career path which I followed. So just to let you know, when we say, as I write DABMG, you can see it, and Arindam mentioned that I'm ABMG board certified. The ABMG represents American Board of Medical Genetics and Genomics, which is a medical specialty considered among 24 other boards, comes under American Board of Medical Specialties. So ABMG board is the only board within the US medical system which certifies also the PhDs. So we do the clinical fellowship for 24 months to 36 months, depends on the specialty. My specialty is clinical molecular genetics. And then we take the board exams, and then we become a board certified clinical molecular geneticist or cytogeneticist or biochemical geneticist. Again, depends on the specialty. We also hold a couple of different state licensure for performing our job, or we call it like for practicing in that particular state. Like right now, I have a New York State license for clinical laboratory director. I also hold a California state license as a clinical laboratory director, and I can mostly, I think, most of the 50 United States of the United States, I can sign out cases. So one of our primary job responsibilities is to signing the report. And that's what I need, those kind of qualifications within the US infrastructure. So, okay, that is kind of like Arindam already told my background. So I worked in the kind of forensic genetics, then moved to the population genetics, worked with Professor Rani Chakravarti, and then moved to the molecular genetics, what we work with Wendy Chang. And then I decided to go for the clinical fellowship, which was from Icahn School of Medicine, Mount Sinai. Then I moved to the job. So today my talk will be briefly. I would touch over about New York Genome Center. I think like Dr. Harold Varmus once visited in IBMG, so he kind of gave an idea what is New York Genome Center because he is one of the faculty here. But I will still give a New York Genome Center about briefly what we do there, then about the Molecular Diagnostic Laboratory, which we also call CLIA, Clinical Lab Improved Amendment Act, which is all clinical laboratories designated as CLIA Lab. Then we will move to our actual talk, which is clinical genome sequencing, and different section in that. They are all kind of overlapped in between, but we will try to cover like cost, time, utility of genome sequencing in a clinical setting. Then with sequencing workflow, genome sequencing workflow, particularly in a clinical setting. Then with the real life case series, which we did, we reported, we experienced through the different collaborative projects. And at the end, I will try to wrap up my talk with the experience and challenges so far for the clinical genome sequencing. So this is a New York Genome Center at the heart of the downtown Manhattan, next to Soho. And New York Genome Center was founded as a nonprofit academic research institute at November 2011, which is almost like 12 years now. It's been founded by several institutes around the New York City as a multi-institutional collaborative hub, focusing on the genomic technology, genomic research, clinical genomics, and all those stuff. And but eventually, New York Genome Center, I would say, NYGC, they have a three focus area, which are cancer, neurodegenerative disease, and neuropsychiatric disease. But the interesting part is on the clinical side or the molecular side, we really don't focus on these three, like not exclusively only focusing on these three domains. We do much more than these three domains. Also, after the inception for last 10, 12 years, we have received more than $500 million grant from the different federal agencies, state and city agencies, as well as philanthropic grant. Like New York Genome Center is actually a big time recipient of a lot of philanthropic grants. And within New York Genome Center, we have experienced so far more than 80,000 whole genome sequencing. But just to point out, those are not clinical sequencing. Those are mostly research sequencing, as we are New York Genome Center is a part of 1000 Genome Project, as well as also Sequencing Hub for TopMed project. So those are the 12 institutes been founded by New York Genome Center, and we call it institutional founding members. The Cold Spring Harbor, Columbia, Einstein, Jackson Lab, Memorial Sloan Kettering, Icahn School of Medicine, New York Presbyterian, New York University, Northwell Health System, Rockefeller, Stony Brook, and Wildcott. And so in the next slide, we will move to a little bit about the background of molecular diagnostic, or which we call CLIA lab. So molecular diagnostic is the clinical wing of the New York Genome Center. And we have a state-of-the-art laboratory system full of automations. And we particularly use genome sequencing, though we do have exome sequencing approval for any clinical lab within US system. When we offer any test or any kind of assay, we need to have approval either from the federal regulatory authority or the state. For us, it's CLIA or it's a New York state. So we do have approval for exome sequencing and genome sequencing, but we really don't offer exome sequencing recent days, or I would say recent years. It's all about genome sequencing. Within our lab is certified and approved by Clinical Laboratory Improvement CLIA or the New York State Department CLEP, and we are also licensed for 50 other states to perform genetic testing. So New York Genome Center, NYGC Molecular Diagnostic Laboratory was the first laboratory. I'd like to mention that we actually have two wings within the clinical laboratory, oncology and germline. So I'm from the germline side, which is a hereditary disorder. I'm not from the oncology side. I'm not licensed to perform oncology testing. But we just do a little bit oncology from the germline side, which is mostly like the cancer predisposition screening. I can tell later during the presentation. So New York Genome Center Molecular Diagnostic Lab was the first lab which got approval for whole genome and transcriptome test for cancer. We do perform, the oncology side do perform normal pair cancer whole genome sequencing as well as whole transcriptome sequencing. NYGC is also the first lab to get the approval for whole genome sequencing for undiagnosed disease and predisposition genetic screening within New York State. And we do run 5 Illumina and over 6,000 instruments for our genome sequencing. So the molecular diagnostic laboratory, we do have a lot of independent collaboration, like other than that, not within the New York Genome Center. We do our collaboration by ourselves as a clinical lab or as a molecular diagnostic division. So there is we are part of one big consortium called Medical Genome Initiative, which is mostly backed by Illumina and formed by total 9 other institutes: Baylor, Broad, Hudson Alpha, Illumina, Mayo Clinic, New York Genome Center, Rady, SICKIT, and Stanford. The SICKIT is only from Canada, the rest of them are from the US. The goal of this medical genome initiative is to guide the clinical field and particularly to help the clinical field to adopt genome sequencing, particularly genome sequencing, as a clinical assay or like genetic testing. So we have different working group and our Chief Diagnostic Officer, Vedi Juganputra, is actually chair of this initiative. And we are different working group, and we do work on different like pipeline working group, quality control working group, reporting working group, databasing working group, all different kind of. So I'm part of the clinical reporting and variant classification working group for Medical Genome Initiative. Other than this, so this is backed by Illumina, but this is nothing to do with the short rate sequencing or particularly the Illumina technology. We do consider all kind of different technologies, short rate, long rate, or different kind of technologies which are available for genome sequencing currently within our domain. We are part of different consortium in terms of like offering clinical genome sequencing. So this is one of we recently wrapped up. This was a clinical trial under Clinical Sequencing Evidence Generating Research CSER Consortium sponsored by NIH, where we collaborated with Icahn School of Medicine, Einstein, Children's Hospital, Montefiore, and we focused on 3 particular disease domain: neurology, cardiology, immunology. And we do have some other projects which are much bigger now. Is a prenatal seq in collaboration with Columbia University OBGYN, Cincinnati Children's Hospital OBGYN. Recently, we have received $17 million funding to create a Women Genomic Center in collaboration with Columbia University Medical Center. We also collaborate with Columbia University neonatal department under the pediatric department, particularly the cardiac NICU, for performing genome sequencing on the infants. And we also collaborate with Wild Content Medicine for running whole genome sequencing as a clinical tool, and particularly focusing on 3 different domains like cardiology, endocrinology, and neurology. So, okay, this is a kind of a brief about the molecular genetics, and and so when we talk about genetic testing, not exclusively about genome sequencing, all over the genetic testing, it's include like microarray, Sanger sequencing, targeted panel, exome sequencing, everything. So what's important of offering a genetic testing within the clinical setup? There's a burden of genetic disease is huge. 6% of the population worldwide is affected by a rare disease. Nearly 80% of all rare disease has a genetic cause. Over 7,000 genetic conditions have been identified so far. Half of this rare disorder cases impact children, and 30% will not survive beyond age of 5 years. That's a huge number. The average diagnosis ODC lasts approximately 7 years. That's the main issue we are facing right now. Even if like genetic testing is almost like 30 years, more than 30 years we're offering, but still figuring out a particular variant or the causal variant for a particular disease, it takes a considerable amount of time. Average time is close to 7 years. Average healthcare cost per discharge is significantly higher for the patient with the genetic disorder comparing with the non-patient without genetic disorder. And we have shown that the critically ill infant with rare disorder, it's really critical for timely and appropriate medical intervention. Also for the pediatric outpatient, it ends the long expensive diagnostic journey. So with the live case series, I'm going to present almost end of the presentation with like 10 cases total. I will show you actual example of this particular last point, how the critically ill infants been helped through the genome sequencing, how we save the time, how we save the cost for unnecessary testing and unnecessary clinical procedure. Also, like how the outpatient pediatric population have been held to genome sequencing. So when the major factors influence any kind of technology, again, it's not exclusive to genome sequencing. There are three major factors involved when we decide or we try to evaluate a technology being applied as a clinical technology within the clinical environment. Three major points are cost of the technology for the regular clinical application are like a huge cost or expensive technology is probably not getting into the clinical application so easily. Turnaround time, that is extremely important. You can understand when we decide, when we handle prenatal cases or we handle NICU cases, neonatal infants, they are critically ill. Turnaround time is the most important factor. So play. We cannot really say like, okay, I have an expensive test that is absolutely fine, that is so sophisticated, that's really good, but I can give you result back 3 months. So that's not going to happen for a clinical team, right? Because they need to do the clinical management ASAP as soon as possible. And there's a third point, which is also the very important before implementing any technology in the clinical field, is the diagnostic and the clinical utility of that particular technology. So the yield and accuracy of the test in comparing to the standard of care. So standard of care is basically the existing technology. Now we are bringing a new technology. So we have to compare, we have to prove that the diagnostically and clinically this technology is maybe not superior. We don't use the superior terms as a clinically. We say non-inferior comparing to standard of care. So I will show you what the technology standard of care and how we are achieving the diagnostic clinical utility, turnaround time, and cost for genome sequencing. So okay, so I feel like this plot is well known for many of you, and because this is this Moore's law, and we are plotting our cost of human genome sequencing from 2001, and right now, if you notice that we have data until 2021 August. So let me go through quickly the history of the cost of sequencing a human genome. So the estimated cost of human genome sequencing was 300 million, approximately 300 million, and it took 15-month periods between 1999, April 1999, and 2000. We know that. And I was just started my PhD that time, it was the year of 2000. So the estimated cost after getting the draft human genome sequencing to the finished human genome sequencing was around $150 million. So now what's the cost of right now, currently, last year, what was the cost? So in NIH or AI specifically in HGRI, each and every year, they do a lot of complex calculations to get a single number, which is definitely not the perfect one, but definitely give us an idea where we are heading. August 2021, the cost of human genome is just $562. That is unprecedented. That is amazing. That's the data exactly, the $562. That's the exact number NHGRI published last year. So if you look at this for last 20 years, for 2 decades, we actually came down from 100 million to $562. We literally removed 6 zeros after 100, which is $562. If you consider our daily life, and at least in the US system, it's less expensive than a high-end smartphone or laptop. So yeah, so this is really amazing, and this sounds really great, but there's a catch. When we say $562, is it covered the whole story? It's actually not. Why? So I will come down to this. So when we calculate the $560, I would say like NHG, or I calculate this particular number, they consider certain parts, they don't consider everything, because that's not possible, because this is really complex. The things they take account when they calculate the cost are these are the things like labor, administration, management, utilities, reagents, sequencing instruments, supporting instruments, informatics, particularly the laboratory information system for production, for producing the sequence. That's a sequence production, submission of data to the public databases, and any kind of indirect cost that related to the above items. But most importantly, what things are actually not accounted when we calculate the cost? Those are mostly clinical side. And those are quality assessment control of sequencing project, technology development to improve sequencing pipeline, which is a constant process when we implement our sequencing pipeline through a clinical pipeline, development of several bioinformatics computational tools. You are almost aware of that how much effort we need to put on this, particularly for genome sequencing, management of individual sequencing projects, informatics equipment, data analysis downstream. This is extremely important for the clinical perspective. Sequence assembly, sequence alignment, identifying variants, and correlating those variants for the phenotype or the clinical correlation. Those are expensive. So how much actually this part would cost if we consider $562? How much would it cost? Probably $1,000 to $2,000. Yeah, it's much more than that actually. So I will go through this. So that's the cost. So let's consider the $562 as the cost for doing the basic human genome, but it's not the exact cost when we come to the clinical genome. So we will see how it's going to have changing now these days. So let's consider time also, which is an important factor. So as I mentioned that 15 months, it took 15 months for the first human genome draft. For the 2021, so how we are moving now? We are moving really, really rapid. 2021, Brady's Children's Institute under Dr. Kingsmore Group, Stephen Kingsmore Group, created a world record. They created a Guinness record actually for doing the fastest sequencing in the clinical setup. That is 13 hours. So they identified a patient with the diagnosis of thiamine metabolism dysfunction syndrome. That's an infant within 16.5 hours after receiving the blood sample, and exact the sequencing and reporting the result happened within 13 hours. That is amazing. You can imagine that from 15 months we came to 13 hours, that too within the clinical setup. So this is this timeline actually shows what exactly happened at what time for this particular patient. This is day of life for that patient, and if you see the exact timing happening and what's how it progressed through the pipeline. This light shaded circles actually represent the timeline within the lab. And if you see, the sequencing actually started at 7:23 p.m. and the variant, the causal variant analyzed through the artificial intelligence or the manual analysis has been reported next morning at 7:34 a.m. It's close to 12 hours. So including the reporting and sending out report probably take an hour long. So it's 13 hours. This is absolutely amazing to think that how fast we can move within the clinical setup. And the patient was diagnosed, again, as I mentioned, the patient was diagnosed with THMT2. The gene was SLC19A3 with a pathogenic variant. The patient was homozygous for frameshift pathogenic variant. But the important thing is how much this whole diagnosis costed for the patient. It was $8,500. So why it is so high? First of all, okay, this is not just the gene sequencing of this infant. This also includes the sequencing of the parents, because we always do trio, particularly for the infant and the prenatal cases. And so that includes 8,500, all three genome sequencing, all three genomics within the clinical setup. That comes to around, I believe, 2,700. That's a good price. That's definitely it's a pretty reasonable price in that sense, I would say, right? But still nowhere close to $562. So you can imagine rest of the prices actually, or expenses actually, we are incurring coming from the clinical implementation or clinical analysis of the genome. And they used Illumina technology that time. Again, this case actually been done in 2019. The data is published in the paper New England Journal of Medicine, 2021. So early this year, we have another publication from the Stanford Medicine. They also reported in the New England Journal of Medicine 12 critically ill patients. And this has been done with under Dr. Ivan Hassler's lab. And they actually analyzed 12 critically ill patients, and they found molecular diagnosis for 5 patients, which is 40% genomic yield. Shortest time for the arrival of the blood sample to the laboratory to the initial diagnosis was 7 hours. That's amazing. And this actually broke the previous record, and this created a new record as a Guinness record again. The fastest human genome sequencing within clinical setup. So this is the diagram that how the sequence workflow they designed, how it worked, and the timeline around that. So this is the patient number 11, which have been diagnosed within 7 hours, 18 minutes. But you can see there are other patients which have close to like 20 hours also been taken. But yeah, this is amazing again, how they did it. And again, the next question, how much it cost? So it costed around 5,000 to 7,000 per sample sequencing. Now, if we looked into again, it's trio samples, and they used Oxford Promethean. If we look into the samples, it's costing around like 1,600. So again, that's coming down. So this too created a buzz, and this is actually there are plenty of studies coming in. Definitely not all of them are creating world record, but there are a lot of prospective studies and clinical trials are going on genome sequencing, particularly in the infant NICU and PICU setup. So what we achieved so far in terms of cost and time of sequencing. The recent efforts have reduced both time and cost of sequencing human genome in clinical setting. The cost is around 1,500 to 2,000 for 6 to 8 weeks. Cost is now 2,000 to 2,500 rapid sequencing within turnaround time of 3 to 5 days, which both the papers actually in that range, rapid most of the rapid genome sequencing, still now we are using the short read sequencing, preferably Illumina, because they have a huge support and they have established for almost like more than a decade, they established the system. So the Illumina is kind of the most still preferred technology, though long range technologies people are evaluating, like Yuan Ashley actually used long range nanopore sequencing technology, but that needs more clinical validation. So when we now, if you see, this was the cost and time. Then the third point was the utility of sequencing of human genome. That's a very important aspect. How we consider the utility, how we look for the utility. The current standard of care of rare disorder may include the single gene testing, multi-gene panel testing, microarray, which we call CMA, chromosomal microarray, or whole exome sequencing, but not the whole genome sequencing. So all these things are kind of considered as the standard of care or first-year test, depends on the what kind of disease phenotype we are analyzing. So this is a nice cartoon recently published in the prenatal diagnosis. So this is, you can understand, this is a chromosomal microarray. What we can detect, the mostly CNVs, exome sequencing, then the whole genome sequencing. And this is a nice tabular format that what we can detect with the genome sequencing, exome sequencing, and microarray, and the targeted gene panel. And right now we are detecting through our genome sequencing pipeline, we are actually detecting SNVs, CNVs, also repeat expansions, also structural variant, but those are very emerging. We are still not going a lot of validation for calling structural variants like translocation, transition, those kind of things. We do detect mitochondrial variants. And exome sequencing, there is a limitation how we actually call the CNVs, because the exome sequencing is based on probe-based capture. So how many probes per exons, and those things are a limitation of the exome sequencing. Copy number variant, CMA, we know that we cannot detect repeat expansion, we cannot detect mitochondrial variant, and so far. And also we cannot detect structural variant exactly using the microarray, and so forth. So this is the kind of comparison how we are moving and what are the technologies we can expect to detect by genome sequencing. So the diagnostic utility, I will try to go through a little quick. Diagnostic utility was like, so far there, again, as I mentioned, there are plenty of studies going on. And WGS has a higher diagnostic yield comparing to WES and CMA. As I mentioned, copy number variant detection is better with WGS compared to WES and CMA. Combining data from 37 recent studies, 8.3 time increase in diagnostic yield when we use WES, WGS compared to microarray. And also, like, this is a huge study, again, by the Reddy's Children's Hospital. There's a critically ill EQ and PQ patients. There is a time of diagnosis decreased by 88%. That is 13 days using WGS and 107 days not using WGS. So that's a huge improvement of the turnaround time and the patient management. Then the third point, so within the utility, we have 3 points: diagnostic utility, clinical utility, and the health economic utility. All these points have their own major influence how we decide as they would go into the clinical setup. Within the clinical utility, this is not exclusive for genome sequencing. This is, I would say, this is applicable to all the genomic testing like WGS, WES, panel testing, basically more like NGS, I would say, next generation sequencing, which eventually replaced the Sanger sequencing. So it's actually prevent additional unnecessary testing, lead to development of new therapeutics and management strategies, and will inform family planning, provide opportunities to psychosocial support by a disease support group. A change in management by using NGS or particular genome sequencing help the clinicians 30 to 70% times they change management, 49 to 70% times for the pediatric outpatients. That's the best on a molecular testing. The management has been changed, and probably for the better management, better care of the life for the infants. Health economic utility is, again, it's not exclusive to genome sequencing, but it's overall the NGS. We have proven so far, like we know that next-generation sequencing-based technologies are much better and much faster and cover much more of the genome to give us a much better understanding what's going on. So this is a kind of figures how much actually been spent and how much time it takes for a patient when it's come to the genomic sequencing, and without genetic cause, without a patient without a genetic disorder, how much time it takes and how much cost it takes to discharge that patient. So last point, the genome sequencing performed when genetic disease is initially suspected provides an efficient economical approach to arriving at a diagnosis. So this is a recent study. There's a nice study again from the Hereditary Genome Institute, because they are the pioneer in doing the genome sequencing in the infant and the PQ. So they keep publishing a lot of good data. They're on the clinical trial. And this is the cost efficacy of rapid whole genome sequencing in the pediatric intensive care unit. So they analyzed 38 children in the regional pediatric PQ who received rapid genome sequencing. Out of that, their 17 patients had a diagnosis, which is 45%. And they calculated the cost in terms, and they kind of like standardized or normalized in terms of quality adjusted life years, which we call QALY modeling. And they calculated that is a saving, cost estimated saving has been 184,846 for those solved patients. For those 17 patients, the total cost of rapid whole genome sequencing, including all 38 solved or unsolved cases, was around $239,400. And so there was enough evidence to suggest that the performance of rapid genome sequencing as a first-tier test or standard of care within the PQ system is acceptable quality, acceptable kind of like. So this is a cartoon which gives us a estimate. The same data, they plotted it nicely, where we see the first is the cost saving, the physician cost and the hospital cost, because we receive the diagnosis much faster than standard of care. So we also received, if we receive the diagnosis, the change of patient care, the patient management happen much faster than the standard of care. And so the hospital cost is also reduced. And so the patient probably go home or whatever care they need, they move fast. So that's a huge saving for the physician cost as a hospital cost altogether, which is close to $200,000. The sequencing cost is around, as we mentioned, is $240,000, and total. This is actually the main parameter we look for. This is the quality of savings. The quality of savings life, quality savings life is around 12 years. Now you can imagine, like if we talk about the standard of care, other technologies already used in the microarray or single gene testing or gene panel, probably this cost will go down here. Sequencing cost will go down because genome sequencing is still expensive compared to the technology. But this cost will jump. This cost will go extensively high, and the quality of life in that sense, again, will probably go down comparing these two parameters. So this is very nice. It's an excellent way to achieve both of this in the standard care of clinical setup. So let's move to the whole genome sequencing workflow when we talk about, so those we know right now, the cost, time, and the utility, how we using, how we achieving, and we are moving towards the right directions of time. So there was a best practice. So this is a part of MGI collaboration where we recently published a best practice of interpretation reporting of clinical whole genome sequencing, where we feel like this MGI, as I mentioned, they do a lot of different kind of working group and propose different ideas or help the clinical field to move around. So this particular work is led by Christine from Harvard and Broad Institute and Vedi from our lab. So this is a cartoon from that paper, or this is actually a general workflow when we talk about clinical genome sequencing, which we divide primarily in three categories. So if you see, this is the light blue color we call primary analysis, and the green color we call secondary analysis, and the last and the biggest portion we call tertiary analysis. So when we talk about $562, we talk about this. We don't talk about this. This is where the cost incurs in the clinical setting. So this is a tertiary analysis. This is where we actually do the clinical interpretation. We do the filtration, triaging of the variants. We apply HPO terminologies, and we go to the clinical nodes. We discuss with the clinicians and all those things. So this is, again, the primary is basically raw sequencing and instrument signals into the nucleotide sequence read. That's the primary category, primary step, and the secondary steps is analysis referred to identification, DNA variants to alignment and variant calling. Tertiary is the most the clinical filtering, triaging, classification of the variants, with your case interpretation, variant confirmation, segregation analysis, and reporting. So that's the most expensive part for the clinical perspective. And this is just, we use different nodes of various types, and that's also include the reanalysis. So within this tertiary, we do have two different way to analyze the data. What we call genotype driven, and genotype driven analysis is basically without a phenotype. We look for any kind of pathogenic or likely pathogenic variant within the genome, and we go from there. We try to look for any of the clinical consequences of those variants. And this is applicable particularly for secondary finding, incidental finding, carrier screening, those kind of tests. And we also do the phenotype-driven approach, where we have a particular phenotype. We actually apply to the series of genes. We know probably those genes are already associated with the disease. And then basically, most of the clinical lab, we actually perform the analysis combining both the state genotype-driven and the phenotype-driven. And then we go to we select a set of variants. For our lab, it's close to 700 variants. From there, we apply the phenotype and all other criteria, and we go down to around 10 variants. From there, we candidate reportable variants, and then there we do the curation based on ACMG classifications. Probably you are aware of that too, and then we do the reporting of the variants. So when we do the sequencing workflow, we actually strictly follow a classification system, which is called ACMG, American College of Medical Genetics and American Association of Molecular Pathologists, which is first introduced by 2015 by ACMG. And it was before that, there was no guidelines. So this is a huge takeover from the ACMG, and that's what ACMG do. And this is actually guideline was part of the Laboratory Quality Assurance Committee, which I'm also a part of that committee. And so we that committee, this 2015, I was not part of that committee. So when they introduced it, so basically the concept of classifying a variant in 5 different sections. How we classify a variant when we see a variant, and probably a gene which is associated with disorder, but it's not necessarily any variant and that gene will cause the disease, right? So there are 5 categories we do. It's starting from pathogenic, which is causing the disease, likely pathogenic with a 90% chance would cause the disease. Uncertain, we don't have much information, it will cause the disease or it will be benign. The likely benign, which we probably have enough information to call it's not causing the disease. And benign, we have good enough information to establish this is absolutely not causing the disease. So this is a spectrum. It goes back and forth, and we actually apply this ACMG classification table. This is a huge table with around 20 different 20 different categories classifying pathogenic towards the benignity or the pathogenicity. And they've been combination with, we go through all different kind of evidences, which is population, computational, functional data, segregation data, inheritance data, allelic data, other different kind of like hundreds of databases. And then we combine those scoring systems, and then we apply to see if it's actually classifying. We can classify as pathogenic, likely pathogenic, or benign, or likely benign, or particularly VUS, or we call variant of uncertain significance. Most of the variants actually get stuck in the VUS after filtering, after triaging for a particular gene. But with time, this is actually keep changing, because this is 2015, and now after that, we realized that there's a lot more things that happened, and there was a particularly okay. So what's happening now, actually, there's a ClinGen community. I'm coming to that again. We keep actually dividing this different categories, like consider PVS1, which is a very strong category, which call loss of function is a known mechanism for a disease gene. And we have a variant with loss of function, but we just don't simply now apply PVS1 for every loss of function variant. We divided it to very strong, moderate, supporting. So you can imagine all this close to 30 different scoring systems have 4 subcategories. That is really huge number of points you have to go through every time you classify a system. But without a CMG classification, there was no way we can report a variant in the clinical setting. So, this is actually a more comprehensive view that what we actually consider as during a classification. We do literature review, we do clinical review, we do computational review, we do population databases review, and we do a lot of intrinsic reviews, like what kind of variant it is, loss of function, it's a gain of function, it's a stop, what's the mechanism is this, it's if subjected to NMD or not, all those kind of different mechanisms goes through in the interpretation of a variant. But after that, we also have to realize that this interpretation classification system are only applicable to SNVs, single nucleotide variant, and mostly indels and SNVs, not for the copy number. CNVs for the copy number variants. So in back 2020, SAMG in collaboration with ClinGen came with the CNV guidelines, and the same concept, basic concept, that there are 5 categories. We could classify them as benign, likely benign, VUS, likely pathogenic, and pathogenic. And from there, if you see, they have designed a kind of scoring system, which is entirely different from the SCMG SNV classification system. And the scoring system, actually, this is, if it's a copy number loss, this calculation is available on the ClinGen site. is the copy number loss. So we have all these points to go through within the 5 section. This is a gigantic task going through all this to classify a CNV. If it's a copy number loss, if it's a copy number gain, we have also this different classification system to apply. So as I mentioned, the ClinGen is actually a genome resource. If you know about that, it's a central resource that defines the clinical relevance of genes and variants for using precision medicine and research. Is funded by NIH and NHGRI, and there are more than 1,400 people right now, with more than 200 institutes working within the ClinGen with different capacities. Most of us are actually part of some ClinGen working group. So the main goal of the ClinGen is to gene disease validity, to evaluate gene disease validity, variant pathogenicity, dosage sensitivity, and clinical actionability. We have a lot of working group, expert working group, gene expert working group, variant expert working group, and we do have sequence variant interpretation working groups. There are actually a lot of people, a lot of working groups that they are working in a different. So what ClinGen does, they take the ACMG, the 2015 guideline, and they run through with different working groups. You see there are some examples of cardiovascular, developmental delay, hereditary cancer, metabolism, particular rasopathy. Those are the different specialized expert panel or working group comprised of the experts from all over the world. And they go through this classification. They try to decide if classification is actually we can directly apply or we need modification. Say they do a lot of modification. And when they do a lot of modifications, and after the modification, they propose a modification that goes to sequence variant interpretation working group committee, and they adopt this modification and they go back and they apply this modification, particularly for that disease or kind of variant or kind of like in silico algorithm, how the in silico algorithm should be scored. This kind of things. If it's a de novo, what kind of de novo scoring should be? There's a heterogeneity involved. It's a confirmed de novo. It's assumed de novo. So there's a particular de novo working committee. All this kind of different committees working regularly, tirelessly putting these things into place. So SVI, which is Sequence Variant Interpretation Group, apply this everything, and then they put the recommendation. Just to let you know the difference between ACMG and the ClinGen. ClinGen is not a medical body. SAMG is a medical body. Even if ClinGen recommend, it only go to the clinical system only when SAMG will recommend officially. So that's the difference between the ClinGen and the SAMG. So again, this is what the SBI sequence interpretation, variant interpretation groups are working, and the different groups. I think I'm running out of time in that sense. I'll try to move it fast. So clinical genome sequencing workflow at NYGC. Again, the same cartoon, there's a primary, secondary, tertiary. So we do offer two different kind of assay, which is rapid workflow, which is particularly for the prenatal and the infant, or infant from the NICU, which a turnaround time for the preliminary is 5 to 6 days. And we receive almost 7 to 8 samples per week. So each and every day we have a rapid running in the lab. And preliminary report means, and then we release the final report within 14 days turnaround time and with orthogonal confirmation. With the New York State regulatory system, we cannot report anything without a confirmation. Even if we know this is variant is actually causal, everything, we can release a preliminary report, but we have to run orthogonal confirmation, like for SMBs. We do run the Sanger sequencing, but for the CNVs, we do run the microarray, or sometimes we do run the qPCR, but we have to have orthogonal confirmation. Without that, we cannot release any report. And then this final report also consists of ACMG secondary finding and sometimes the pharmacogenomics finding if consented. Our coverage matrix is 30x plus minus 3x. Anything below not be get reported will resequence. We use GRS 38 as the reference build. And what we report, SNV, indent, CNV, and mitochondrial DNA. And what kind of variants we report? Pathogenic, likely pathogenic based on SMG classification, and strong VUS. Strong VUSs are the VUSs which have just not enough evidence to call it likely pathogenic, but we always consult with the clinical team before reporting out, because it's a VUS, probably the clinical team would not change the management based on a VUS. But if it's a strong VUS and they read reported, probably they would think about that. Reporting section for rapid, we generally have primary and secondary. And this is the regular workflow, which is around 4 weeks, and there's no preliminary report. It's a final report, 4 weeks turnaround time. It's mostly the pediatric populations or adult onset or late onset disease disorders we sequence, or we're working with that groups. The same coverage and the build is also same. And here there is another exception we include is we do report repeat expansions, which was not part of the rapid workflow, because repeat expansions are mostly Fragile X, Huntington disease, or Friedreich ataxia, or a bunch of cell birth, a bunch of spinocerebellar ataxia. Those genes are late onset, or probably probably adult onset, or in the late stage, or probably in the pediatric population, but they are not relevant when it comes to the prenatal or the infant stage. So we only report the repeat expansion for the regular workflow, and we do report hepathogenic, likely pathogenic, and VUS. It's not necessarily we always report the strong VUS. We do report some VUS. It's probably going towards benign, but they don't have enough information, because this actually goes a little bit on the research, as we report them as a supplementary, not as the main primary section. Primary section always consists if there was a variant associated or explaining the phenotype. If it is not, the primary section will be reported as negative. In the supplementary, we do report variant of uncertain significance, when physicians actually sometimes consider those variants, and they do a little bit research to see if the phenotypes actually matches. So this is the pipeline, actually bioinformatics pipeline we use. So we do the BWA alignment, and we they use different like GAT capital type color. We are recently moving to Dragon, which is Illumina pipeline, Dragon 4.0, which has been released last 2 weeks. And we are actually getting approval from New York State for doing that. So whatever we do, each and every step, it's being in the lab, or it's updating our pipeline, or updating our instrument, we always have to get New York State approval for that. So we are in processing of that. We actually received it. And those are the algorithms we used for detecting repeat copy number, SMN copy number, which are pseudogenes or homologous genes particularly, and mitochondrial DNA, and then again the tertiary analysis and variant interpretation. So case series, I'm going to show you real life case series and how we actually do it, and how the clinical management actually get impact. So I have 4 different sections, which is prenatal, where we offer rapid genome, neonatal case series, and the pediatrics, which are rapid genome 2, pediatric population, which is not neonatal, but it's 3 years and more than that, and adult onset disorders, which we consider it and like 40 plus or something like that. So the prenatal, this is a project called Prenatal Sick. It's a clinical trial. We are the joint collaborator with the Columbia, where particularly we are looking for the feasibility or clinical utility of applying genome sequencing in the prenatal setting. And that's how it actually can save the cost, how can we improve the prenatal care, reduce the unnecessary diagnostic testing, and so far. So it's as I mentioned, it's a Columbia University is the main sponsor. There are a lot of other institutes. New York Genome Center is one of them, and we are actually sequencing partner of Columbia, and PI is Dr. Wagner is the PI for the Columbia University OBGYN department. So just a quick here before getting into there was no data so far for the genome sequencing in the prenatal. The recent data, which published the February 2022, is actually meta-analysis of exome data. So we are pretty new in this field applying genome sequencing, and so far we did so far, I think, close to 300 genome sequencing for the last almost 7 to 8 months. This is a pretty big project, and we are doing really good on that. So this is a table which published the meta-analysis of exome sequencing data, which shows the diagnostic yield over CMA. If we just consider the patients we didn't have a diagnosis using the standard of care, what's the yield? How many patients after that actually get the diagnosis? This is actually great. This is actually they studied 4,300 fetuses, and that is 31% patients actually get a diagnosis just using exome sequencing over negative microarray data. That's a huge number. And if you see, and that's an interesting thing, that's a well-known concept, that's diagnostic yield actually varies from phenotype to phenotype. As we know that there are some genes or some disorders are extremely heterogeneous, and there are a lot of multifactorial genes involved, like congenital heart disorders, CHD is one of them. We also know, like, when it's come to IUGR, like fetal growth restriction, that is something like there's a very broad phenotype in the prenatal stage. That's the issue with the prenatal stage because we rely on the imaging, ultrasound imaging, right, when we do the analysis. And ultrasound imaging is more prominent when it's come to skeletal disorders, but ultrasound imaging is really not specific when they just say, oh, hey, the fetus only have like isolated increase in T, nuclear translucency. So that could be associated with 100 of genes, right? So yeah, if we see that it's actually keep decreasing, it's been ordered in the descending way, and 53% of the skeletal, whereas 2% for the NT increased nuclear translucency. So in conclusion, for this study, the prenatal ES sequencing provide diagnostic additional 31% of structurally abnormal features over the CMA karyotype. And we are actually expecting more for the genome sequencing, but we don't have the data ready yet. So expected diagnostic yield also correlates highly with the phenotype, what kind of phenotype we are analyzing. So this is a real-time case which we reported. I will go two cases for prenatal. There was a male fetus, gestational age was 23 weeks, 3 days. Indication of the test was polyhydramnios I anomaly, possibly cataract, left orbit, hypothyroidism, proboscis, holoprosencephaly all over, increased nipple fold, pericardial effusion, dilated bowel, cleft foot, unilateral cleft lid, clenched hand, and the consanguinity was reported. This case was negative for microarray. What we found, VPS50, a gene, we found a stop gain homozygous variant in this particular gene, which we classified as likely pathogenic. And this gene is particularly not reported as mean as a gene association study, like gene association with any disease, but there are two patients reported, unrelated patient reported for this particular gene, VPS50, with kind of overlapping phenotype, but those are noted that those are in frame deletion. Homozygous, one patient was homozygous for in frame deletion, another patient was homozygous for splice site variant, which was actually resulting in frame exon skipping. So they are both kind of survived and they have the postnatal phenotype. And this is the SCMG classification, how we do it. This exon, the population frequency is absent, in silico prediction, and the functional evidence from these two previously reported patients. Based on that, we classified this as likely pathogenic. And the clinical management, the parents decided to term the pregnancy. The pointer here is, the moment we got this variant, our clinical team actually started reaching out through the gene matcher throughout the world. If any clinic actually got a variant, which is loss of function variant for this gene in the fetus, we got a hit from the UK. There was a clinic who they also got a variant, which is splicing variant again, which is a loss of function variant, homozygous, and the fetus actually didn't survive. It's a demised fetus reported. So based on that, so here in our case, the parents decided to term the pregnancy, but we believe other than that, they would have actually demised fetus, because we believe this VPS50 loss of function variant or null variants are actually prenatally lethal. That's why we don't see them much being reported. We do see here and there postnatal with inframe deletion, not loss of function, inframe deletion kind of variants, but not loss of function variants. So there's a very interesting finding. So we are working on the brain tissues and some mice model from the UK in the collaboration. We'll see if we'll publish a clinical study on this. Case 2 is also a female fetus with a gestational age of 22 weeks, 5 days, indication of hypoplastic left arm, aortic valve atresia, mitral valve atresia, hypoplastic ascending aorta, hypoplastic transverse aortic arch. This was a negative CMA. And the interesting part here, even if it's a negative for the chromosomal microarray, we actually identified a copy number loss in this gene. And the copy number loss was 5.5 kb, which is below the threshold of detection of a clinical microarray. And this is it's a copy number loss, and it's a de novo, and it's a heterozygous, and it's actually deleting partial of exon 6 and exon 11. So this particular gene, MYRF, is associated with cardiourogenital syndrome. And this is the classic clinical characteristic, which include the 70%, which also include the hypoplastic left heart syndrome is the most common form of the congenital heart defects for this MYRF patients. And again, this is how the MYRF, we classified them as a likely pathogenic. This is one of the important domain. It's removing one of the most important domain of MYRF, which is DBD. And the patients actually, the parents actually, the fetus decided to continue the pregnancy. So, there's another case, which is a female fetus at, again, 24 weeks, 6 days gestational age, fetal anomaly, micronathia, pontibossing, bilateral bands of frontoparietal scalp, absent of hands and feet. There's also severe phenotype. This was negative for CMA, karyotype, and FISH. We identified a de novo missense heterozygous variant at GJ1 gene, and this is associated with ODD at a phenotype called oculodentodigital dysplasia, which is not very common. It's 80 patient reported worldwide. And clinical features actually include as a craniofacial, the limb defects, and you see that the absence of hands and feet actually indicates there's a limb defect. There's a high penetrance, but there's a severe variable expressivity within the intra and the interfamily, even within the same mutation. Interesting part is this particular mutation has not been reported, variant has not been reported in any patient, but this particular residue, not this variant, this particular residue at glycine 60 has been well studied in the mouse model. And the mouse model carrying this particular glycine 60 serine change, which is here, G68, actually exhibit a classic symptoms of ODD, which include syndactyly, enamel hyperplasia, kind of facial anomalies. Parent decided to continue this pregnancy based on this result. So we moved quickly to the neonatal, which is actually a part of Columbia University Department Pediatrics. And it's a prospective study. It's not a clinical trial yet. It's a small study we performed, and we performed close to like 48 patients from a neonatal setup, cardiac setup. So this is the first time we're looking for the rapid genome sequencing, how they improve the care of infants with the congenital heart disorder. As probably you are aware of that, the congenital heart disorder, extremely heterogeneous disorder. It could be divided in isolated CHD or syndromic CHD. Isolated CHD means only the CHD as a phenotype. Syndromic is a part of CHD is a part of a syndromic phenotype. Anyway, so this is sponsored at Columbia University, and a team of people include here neonatologist, cardiologist, surgeon, geneticist, genetic counselor, and Wendy is a PI of this particular project. And so we just kind of wrapped up this prospective study and we submitted the manuscript. And here there is a cohort of 48 newborns. This is a really good finding. Like we have diagnosis for 27% of patients. 13 patients have been diagnosed. Sorry, what's happening? 30 patients have been diagnosed. And out of those 13 patients, 7 patients actually have change in clinical management. That's a huge 54% patient have been changed in clinical management. So I highlighted these 2 cases. I'm going to show you pretty quick that they have a change. That's actually for this molecular diagnosis, based on molecular diagnosis, which helped avert intensive or fertile intervention. And there's 3 cases, which are all cat-eye syndrome cases highlighted in green boxes. The interesting part of this case is if you see, they are all actually duplication in 22q11, which we identified, and which is classically associated with cat-eye syndrome. But when the patients actually came and the physician asked for the genomics testing, they had no idea those CHDs were part of that particular syndrome or anything like that. They asked for as isolated CHD. And then they turned out with this particular findings, they were actually not isolated. They are syndromic, and the patients actually have cat-eye syndrome with a lot of different other abnormalities, which is definitely not visible at the infant level within a week or so. So there's a change of management. They immediately rushed to the ophthalmology and some other concerned departments. This is just a research studies how the yield of genomic, there are not much studies again. So when it's a syndromic CHD, we have a higher yield. Our cohort of actually is 50-50 between isolated and CHD, and this is genome, we are kind of in the same range. So the case 1 is a 2 weeks old critically ill female infant with omophyllary, correctation of aorta, ventricular septal defect, alveolar capillary dysplasia. And we identified a gene, we identified a variant in the FOXF1 gene, which was de novo, which was frame-stripped, and which was heterozygous, which was associated with alveolar capillary dysplasia, and which is a known variant. And the disease is uniformly known fatal at the newborn period. So anyone carrying this particular variant, the likely pathogenic variant within this gene probably would not survive within the newborn period. And this how we classified this. This variant actually reported in 400 patients with alveolar capillary dysplasia. And the patient management, the patient actually died out of death of respiratory within 5 weeks. And we knew it. And the moment we saw the FOXF1 variant, we immediately knew that this is going to happen. There's no way that patient can survive. So they actually decided to change on the ECMO management and the surgical candidacy management, and they decided not to perform any kind of surgical procedure, and that will actually would actually avoid giving a false hope to the parents about incurring more cost for the expensive surgical procedures or the hospital care. In the case 2, there's a 2-week-old critically ill female infant with a hypoplastic left heart syndrome, HLHS, and dysphormic features, severe microcephaly, low tears, micronathia, high arch pellet, broad nasal bridge, and right hip dislocation. And we found a KMT variant of the KMT2D gene, which was also de novo, which was also frame stripped, and which is associated with the Kabuki syndrome. And particularly Kabuki syndrome, they have 70% of Kabuki syndrome do have the features of the KSM, congenital heart defect. And this is the criteria we use for classifying this as a pathogenic. And the patient management changed, that they actually avoided redirecting the comfort care goal. Instead of performing cardiac surgery, they actually avoided cardiac surgery. The clinical team decided not to perform that because within the robotic system, even they perform the cardiac surgery for HLHS, that's not going to actually improve the patient quality of life. So they decided not to do that and put the extra burden on the parents. So in the pediatrics, I will just quickly move. So this is another clinical trial. We are part of that. We did more than 1,000 sequencing for this, particularly with the combination in collaboration with Icahn School of Medicine, New York Children's Hospital, Montefiore, Albert Einstein, assess critical utility, particularly to assess the clinical utility of genome sequencing in the pediatric disorder, 3-category pediatric disorder: neurology, immunology, and cardiology. And also, this is a unique part of this particular assay. I'd like to mention this assay targeted, this clinical study targeted the underprivileged children from Harlem and the Bronx, particularly the African American and the Latino community, which are severely underrepresented within the genomic databases or within most of the clinical trials evaluating the sequencing based studies. So it's been sponsored. We are the collaborators, and Dr. Gal was the PI for this study. So I would actually, we are communicated 3 different manuscripts from this study. I just don't have, for the time, I will just move quickly. We have a great findings, which showing that, that we compared the target gene panel and the genome sequencing, which showing the higher yield for the genome sequencing and lower genetic yield for the African American, which we know. I'm not getting into this table right now. We also have shown there was another manuscript which also have shown the copy number gain is much higher. Copy number variant detection is much higher in genome sequencing compared to the microarray, which is 30% cases were undiagnosed, and we found there is a copy number reportable or likely pathogenic or pathogenic copy number variant. This is just a chart on that. We also showed another manuscript that genome sequencing actually can reliably detect mosaic variants. So I have few cases here. I don't know if time, should I stop or just go to the, I don't know, or should I continue? Okay, let me just continue.
Yes, please go ahead. I mean, maybe another few minutes, so it should be fine.
Okay, I will just try to, we're almost done. Yeah, so that's case 1 for the pediatrics. So I will try to show you 3 cases, 1 from CNV, 1 from the mosaic, and 1 from the just general case for SNV. So there's a 3-year-old male with a mild to severe GDD, global developmental delay syndromic without autism spectrum disorder, protruding tongue, small penis, hypertonia, and poor language skill. This case was negative for CMA as well as exome sequencing. But we found a deletion at SOX5, which has been missed by microarray, which has been missed by exome sequencing. The deletion was 3 kb single exon deletion, which we understand why it's been missed by both the technology. This was below the threshold for CMA, 3 kb, and for single exon deletion, it generally doesn't get called during the WES or exome sequencing. Anyway, this is the frame shift loss of function variant, which is associated with Lamb-Shepard syndrome. There are not many patients reported, 70 patients reported so far. And we know this is haploinsufficiency is a known mechanism, so we call it, and the clinical management was basically, there's no clinical management change, but it actually shows that identification of the causal variant and end of the diagnostic was in Odyssey, which could be continued for 7 years, 10 years so far. Case 2 is a old 5 years old female with severe IDD syndrome, with autism spectrum disorder, tall for age, heavy and macrocephaly, basically overgrowth syndrome. It was negative for CMA. We identified a variant, a DNMT3A gene. And this is a very interesting variant, actually. I just wanted to show you this because this variant is associated with Tatum-Brown-Raymond syndrome. It's a well-known pathogenic variant, but if any of you are actually aware of a concept called CHIP, which is a clonal hematopoiesis of intermittent potential, where actually a somatic variant kind of get linked to the germline lineage, DNMT3 is a top gene which is common for the CHIP. And we do observe a lot of CHIP variant in DNMT3A. How actually that surprises you? So when we are looking at the variant, it's an autosomal dominant disorder. And if you check this variant frequency of the population databases like NOMAD or TopMed, there are close to 90 heterozygous individuals with this particular variant. That doesn't make any sense to calling it a pathogenic. But the beauty is when you looked at the variant allele frequency, which is 19%, variant allele fraction, sorry, not frequency, variant allele fraction of the alt allele, which is 19%, and also age is kind of skewed to the higher side, which tells us this is probably a chip variant, and this chip is associated with age-related chip, and that's exactly happened to this variant. This is a well-known pathogenic variant, which is a germline. When it's actually in the germline, it causes you Tatum-Brown-Raman syndrome, and this particular residue is extremely important. And when at the somatic side, which probably causes you the somatic like malignancies, the leukomegenesis is the kind of thing. So yeah, this is something. This is a reminder, the great reminder in our pipeline. Within our pipeline, we do use artificial intelligence, and we also do the manual inspection of each and every variant we report. This is a great reminder that AI is great, but AI is still not there to replace the human effort, because this kind of variant could have been missed just considering the high population frequency. AI cannot detect those kind of things. Anyway, this is just an example I wanted to show you. This again, there was no clinical management change. It's the identification of the causal variant. And the case 3 is a Caesar 8-year-old female, and we actually identified a variant as a mosaic variant, a 20% variant allele fraction, which is a missense variant, which is heterozygous. There is not many cases reported for this particular gene, which is factor 1, and developmental epileptic encephalopathy, and 5 cases been reported. And this particular variant explained the seizure, but not the severity of the reported patients for this particular gene, because we believe that the mosaicism plays a role, which actually creates a milder phenotype for this particular patient. So do we have another project which is adult onset? We work with the Weill Cornell, basically prospective is also prospective evaluation study is an implementation of large-scale genome sequencing, particularly for cardiovascular, metabolic, neurodegenerative, as well as for oncology. But as I'm not part of oncology, and as Weill Cornell is a sponsor, there are multiple investigators. We have a case. It's a pretty straightforward, like we do what kind of testing we do for here. 50-year-old male with hyperlipidemia. We have a pathogenic variant, which is in the LDLR gene, which is associated with hypercholesteremia. And there was a clinical management. Basically, they will monitor the hyperlipidemia. They know now what are the genes. And the case 2 is a patient with the ventricular arrhythmia, part of cardiology department, Weill Cornell, and we identified a TTN gene. It's a Titan gene. If you know, this is one of the longest gene with 363 total number of exons. So we identified a stop gene that we classified as likely pathogenic. And if you notice, there's inheritance is unknown here, because mostly we do a single proband only sequencing for this project, not like trio for the previous projects. Anyway, we classified this as a likely pathogenic, and we reported it. And there's another part we actually report as ACMG secondary finding. If you know what is ACMG secondary finding, the ACMG secondary finding is the kind of findings which are not associated with the phenotype, but those are clinically relevant. These are the genes. We have a list of 78 genes which are recommended by the medical body at the ACMG, and they actually recommend us that if you see them, you have to report it. So initially it was incidental finding if we see them. Now it doesn't work like that. We actually look for those genes. So it depends on if we report ACMG finding or not. So it solely depends on the consent of the patient. Patient during the counseling session, patient have been asked, hey, these are the things. If this is your primary phenotype, that's fine. But we have this ACMG list, which is recommended to report. So the concept is here, by default, we report ACMG findings. So this is we called opt-out option. If patient doesn't want, they have to sign to opt out from that by default situation. So this is the concept, because we believe the reporting of this is advantage, or it's actually help the patients. Anyway, so we can say like, hey, so this is the thing that if we report ACMG, probably you would have seen pathogenic variant in BRCA1 gene. So it depends on the patient if they consent or not. So this is 78 lists, and this is the gene list we keep updating from version 1. Now we have the recent one, which is published in this year, in the month of May. And this consists of 78 genes, and these genes are broadly divided in 3 or 4 sections, genes related to cancer phenotype. So mostly the genes included here and how we report them, the variants reported report, pathogenic, likely pathogenic, their inheritance, or maybe number, why these genes been included. There are certain level of medical management, either monitoring, or there's a therapeutic options, or there are change of like healthy habits, or those kind of things. There's a certain level of management available, clinical management available, so we report those genes. So again, this is the genes related to cancer phenotype. These genes, again, reported to cardiovascular phenotype. There's a lot of genes on the cardiovascular phenotype, and third set of genes are related to the metabolism phenotype, and there are some miscellaneous phenotypes also been included. So with this, in conclusion, what are the experiences? Experiences lower sequencing cost and turnaround time could be achievable. As we've seen that, first and turnaround time can influence the medical management and significantly reduce the burden of healthcare cost. Genome sequencing is non-inferior compared to CMA and WS and potentially could be used as a first-year test. Genomic test yield is highly correlated with phenotype and some extent with ethnicity. So the experiences so far we have, but when we talk about challenges, there are a lot more challenges actually. Not enough diagnostic utility data to adopt genome sequencing in a regular healthcare system. As you have seen the prenatal, this is the first time, the first clinical trial is actually we are conducting for the prenatal space. So it will take time. So there's not enough data, honestly. There are plenty of studies coming in, but we need to have more data to convince the clinical world that genome sequencing can solve as a healthcare system. Not enough infrastructure within the healthcare system to support the adoption of genomic sequencing. This is very, very complex system. Introducing this kind of a pipeline from collecting bloods and reporting and bioinformatics and software engineering, hardware infrastructure, there's a lot to achieve with this rapid turnaround time. Actually, we do cloud computing right now. We use Google Cloud Platform and for storing and analyzing our data. But this infrastructure is a lot less expensive and they need a lot more support. Still evolving for the complex genes. The genome sequencing still, like recently, we actually adopted GBA for the part of Dragon guideline. If you know the GBA, it's associated Gaucher, which is known for there's a high homology and pseudogene. And there are a couple of other pipelines we are working closely with Illumina. We actually closely work with Illumina for developing challenging genes pipelines or analysis pipeline, like C21A2. And if you know that thalassemia, those are homologous or the similar genes. But still, we have a lot of work to do on this genome sequencing space for this challenging genes. Burden of clinical interpreting large number variant of uncertain significance, the main difference between WES and WGS, we ended up getting a large number of BUS variant of uncertain significance within the intron, deep introning. Probably a lot of them are actually splicing impact. We don't know. For doing that, actually, many labs, not clinically, but including us, we started doing RNA-seq in combination with this kind of genome-seq, but that's in the background we do on the after discussion with the clinicians. We do the RNA-seq and we do look for any kind of splicing impact. The burden of genetic counseling, that's increased huge because we have a lot more variants, we have a lot more things coming up. So that's increased the burden on the genetic counselors, how to counsel the patients. Currently, the genomic testing is not considered as the first tier or standard of care, so it's not reimbursable by healthcare insurance, prohibit widespread accessibility. Data storage, privacy issue, legal and ethical issues are always a bigger challenge for any kind of genetic testing we get into. So yeah, with that, I'd like to thank and I'd like to acknowledge all the patients and their families. They consented for this sequencing to look for their things. And without obviously their consent, none of this studies are possible. And particularly to Lady Eve, who is a chief diagnostic officer of NIGC. She's also a professor of pathology and cell biology, other clinical directors, bioinformatics team, clinical genomics team, clinical laboratory team, genetic counseling team, clinical administration team, and the software engineering team. Yeah, I think I'm pretty much way over time. Thank you so much for that. Yeah.
Thank you, Saurav. That was simply wonderful. I wish we had more time, and definitely next time you are in, we'll probably have a physical meeting and a presentation that will help us to interact much better. So while Alpana finds out if there are any questions on our YouTube, basically Parchuda and some of our faculty members are already in this Teams link. So I would request them if they have any questions, they can just say, or remarks, they can do it now.
Sure.
So I think my colleague, Professor Anupam Basu, has a question. Anupam, please shoot.
Yeah, Arindam. So I'm traveling. I don't know whether I'm audible or not.
You are.
Yeah, great. So fantastic talk. I just congratulations.
Thank
My
you.
question is all fundamental question. You have shown some heterozygous variants. They're still pathogenic, but how do you think they're clinically relevant for diagnosis?
So when we call a pathogenic, we only call them based on ACMG classification system. There are certain, right? So it's clinically, that's the whole concept of applying SAMG classification system. It's not that a variant has been reported in a patient and we will just call it, oh, it's pathogenic. No, it's not. We look for several, it's close to 300 criteria we go through to make it call it pathogenic. And always we say based on SAMG classification, and clinicians are aware of that. So that's the clinical relevance of like, that's probably the variant which is actually solving, or did you get, sorry, yeah.
My point is that pathology is exit, but as experience, how the clinical really change.
So the clinical event, that's why I showed there in the prenatal space, or particularly in the neonatal, how the management has been changed, right? Based on the diagnosis, how the management has been changed, how the cardiac surgery has been avoided, and that's actually avoided a lot of healthcare costs. That's avoided a lot of emotional stress on the parents. So all these things are part of clinical relevance, right? When we talk about how the clinical management changed, clinical management is a much bigger perspective. It's not just how drug is there or not, something like that. It's actual hospital cost, it's actually the emotional stress, it's actually emotional burden on the parents, and the next pregnancy. And also, like when we report something like that, we have to keep in mind that the counseling actually tells the parents that the possibility of the next pregnancy, how they, like in the prenatal, we actually analyze many patients, they have several recurrent miscarriage. And so we get the answer, this probably the variant, you are getting the miscarriage. So that's how they will go for the in vitro diagnosis, artificial ART, and that's how they process. Yeah. So that when it comes to the clinical relevance, it's much broader in that sense.
Oh, that's great. By small queries, basically. Just
Yeah,
last
right.
point.
Yeah.
It's not part of your talk today, but how the prospect of NIPT
Oh, okay.
for the
Yeah, I actually worked in NIPT for 3 years. And so I have a very personal experience with NIPT. I say it's not NIPT, it's NIPS. It's a screening test. It's not a diagnostic test. So probably you are aware there's a big controversy happening from the New York Times article. So I actually worked in Illumina West when I was back in my previous lab, which was cancer non-invasive prenatal screening. So that's a huge prospect. Definitely, right now we only detect chromosome 18, 21, and 30. There's 3 aneuploidies and 5 CNV detections are there. But now the clinical space is actually moving more, detecting single nucleotide variants and some those kind of things in NIPT. So, but yeah, NIPS, I would say NIPS. Again, remember, NIPS is a screening test. Whenever you get NIPS result, you need to go a diagnostic confirmation in the prenatal time using amniocentesis or CVS. So this, yeah, but there's a huge prospectus there.
So Pathuda, I think, has.
Thank you.
Pathuda?
Yeah, I think Parthoda is mute.
Pathuda, you're muted.
So I said that was a good talk. I still can't turn my camera on, so I don't know what happened. But anyways, I'll ask. I have 3 small questions. One is that as you are, you detect a variant and then you go through this 5 stages, benign to likely benign, etc., so on, up to pathogenic. Is there, and of course, these are elaborate protocols by which you classify a particular variant into one of these 5 types. Do you do that manually, or are there some software packages that help you do that? In other words, is there a lot of manual intervention done in order to classify these variants into one of these 5 types?
Right. So yeah, Partha, that's absolutely great question, because we do manually. And every time, and we believe we are going to do manually for a long time, because so far we, as I mentioned, we do use artificial intelligence software. So in our pipeline, we know there are other programs available. The clinical field do use it, but we are all in the same page. As I particularly showed, if you remember, the variant from the DNMT3A, which is a really high frequency in the nomad and topnet population databases. AI-based pipeline, which we use, actually missed that variant. So it's been actually picked up manually. So manual is mandatory, and that's how we trained. That's how we do the fellowship and all this. So many trained persons in the field for doing it manually, because we believe that. Or it's I would say it's more like semi-automated. Artificial intelligence is still not in a position to actually make it a call. Probably they would make 90%, but they definitely would make 10%, and that 10% could be costly. Yeah.
So it's a combination of
yeah, but yeah,
machines
again, it's a
and
combination, but
humans.
each and every variant, each and every case, each and every reportable variant, or at least shortlisted triage variant, go through manual curation. Pages after pages, we do the curation. Each and every variant, they have a full pages, like 3-4 long pages, all the literatures, and we actually go through all the pages and present. And we actually meet with the clinical teams at least twice weekly with different projects, and we go through the different presentations and tell them this is the PM2, this is PP2, this is PS2, how are we applying it, how are we modifying it, how are we waiting, and this. Yeah, there's a lot of, actually, I would say, like 25% of our job, we actually spend variant classification of 25% of our job responsibility. We just spend on the variant classification. Yeah.
Good. My second question is, does ACMG mandate reporting of variants to the databases such as Nomad or TopMed or one of those?
No.
Is it mandated that you need to submit that?
No. So ACMG, first of all, ACMG doesn't really interfere in databasing or laboratory thing. ACMG is more as a medical body. They actually try to guide the labs how to report, but they don't care if we submit it. That the part is actually mostly done by the clinician community. And that's why the ClinVar is the main site where we submit. So now most of a lot of clinical labs, they don't. There's no mandatory, but if we submit or not, it actually depends also on the project itself. Clinical project, the clinical trials, what's the mandate, when we get funded, and what's the the collaborations with the other PIs want. So that's more like this, but there's no mandatory information. Sure. Yeah.
And my last question is probably a silly question in the sense that, let's say that you identify a particular variant. Is it possible that that variant in a pediatric population is pathogenic, and in an adult population it's likely benign? Is that possible?
I doubt, because what happens when you say likely benign? So probably you would have when you say likely benign, you would expect it to see a lot more in the population, right? Because that's likely benign. So by natural selection, it will be there. But if it's already in the pediatric population, so if there's a phenotype associated with the pediatric population, so those pediatric population would not be probably part of any databasing which covered the adult onset or the Nomad or TopMed and that kind of thing, right? So there's a very unlikely situation that variant will probably get into a database. First of all, it's a pediatric population. Like I can tell you one important aspect when we consider which database we are using, like Nomad or TopMed, and now we have all of us. Which database using, it's very important to understand what's the background of designing that database. Nomad was designed for pediatric population, not for adult onset population. Like the hyperlipidemia, if there's a pathogenic variant, you would actually see a lot of variants there, maybe 10, 15, 20, sometimes that range, because the population the database was designed to exclude the variant which was pediatrically, those are pathogenic, but not adult onset. And so there's a 30-year-old person which is part of the database, and absolutely asymptomatic, probably carrying a hyperlipidemia variant, which will show, or the symptoms will manifest at the age of 70. So you can imagine that that's important to understand which database they're using as a reference. It's a Nomad. For TopMed, they have a different concept. The TopMed is actually the database. It's not exactly a healthy population, rather than it comes from the Blood Heart Research Institute, and they have a lot of patient population. So yeah, so I would say, again, going back to your question, Partha, that's very unlikely. This is something is a pediatric population, is a pathogenic, and it will be turned benign. That's very unlikely.
Is the opposite likely, that it's likely benign in the pediatric population?
Yes. So we would not say likely benign, Partha. We would say that particular variant is adult associated with late onset disorder, which would not manifest during the pediatric age time, right? We would not say likely benign. We would say it's still pathogenic, but it will manifest, the variant will actually manifest the phenotype at the late onset, right? So that's the concept of how we tell. Yeah.
So even if you're trying to do some kind of a diagnosis in a pediatric population or in a child, you actually have to look at adult databases.
Yes, right.
Okay.
Yeah.
All right.
Yeah.
So I think Nidhan has a question.
Yeah. Again, I am also traveling, so maybe a little noisy. So my question is, between these two sequencer currently on market on Illumina and versus long read like Nanopore. So what's your feedback on using them in the diagnostic market? Like, what's the success rate of using Nanopore solving these complex cases? I believe that Nanopore probably is portable and can be set up at the remote locations and stuff. So of course it's easy to put things into clinical place in remote locations. So uh, would you use Nanopore for disease diagnosis in such scenarios?
So yeah, so one of the great thing working at NYGC that we closely work with all this platform. We don't have any biasness. Like, okay, we use this. So Illumina is definitely the one we started using. And the interesting part is a part of NYGC is actually Nanopore's headquarters in New York City. So Nanopore's New York City headquarters is part of NYGC. We rented them a space, so we just sit with them. So anyway, so we do actually. Honestly, I never used Nanopore clinically because we still not using it. But as you mentioned, our clinical our production or the research team actually validated recently the issue there are other than just the technology, there are other issues there involved when we talk about applying it to the clinically. What are the things? Like you mentioned, there's a portable, absolutely great. You can put it in a corner of a room and you can use it. But think about that. When you talk about a clinical lab, you are not going to do one or two sequence, right? Like weekly one or two with a small machine sitting next to your table. You're not going to do that. Probably that's not going to feasible. That's not going to be make it profitable or anything like that. You will look for a large scale operation when it's come to clinical. You are thinking about applying a clinical technology. You will probably talking about 5,000 patients per month in a big hospital system. That makes sense, right? So that's the one thing. So the portability is fine. It sounds really nice, but I'm not sure that how much that actually helps when it comes to the clinical applications. Okay, for small labs, probably they can do it. Great. Technology-wise, absolutely. The long-read sequencing actually proved that they are much better than short-read sequencing. There's no question about that. But the short-read sequencing, I would give an example like repeat expansion. So when we talk to the repeat expansion or the pseudogene, long read sequencing is much better detecting them because we know that the reads are actually shorter when it's actually shorter than the actual repeat expansion. So that's actually started falling for short read sequencing. But the beauty, or at least again, I'm not biased for any particular company or any particular technology, but working this field for last 10, 15 years, I can tell you for last 2 decades, that Illumina created a space. As I will not say probably it's a monopoly, but the thing is Illumina's support system from getting to the machine, running the machine, the clinical implementation, designing the algorithms, working around the patient community is a huge. You can think about our consortium, which is the part Medical Genomic Initiative, which is backed up by Illumina, knowing that it's not necessarily we are just going to do the Illumina. We are also recommending different kind of technology ability. But Illumina's support system actually worldwide is so huge that support system is completely absent from any other long read, either PacBio or Nanopore. So we don't know yet. And if you know, there are 2 other companies this year, AGBT, early this year, 2 other companies actually came up. One is Ultima, another is Element, I think. So Ultima is also short read sequencing, but not pair by parent. But that's actually, they are promising $100 genome. And we are also a beta partner of them. We already have machines along with the Baylor and partner. We are evaluating short read. That's anyway. But the thing is, the main issue when it comes to the clinical support system from all over the team, all over the machines. So in that sense, that's why you see, even if Johan Astley Lab from Stanford Medicine, they applied Nanopore and they really achieved good data and they solved the cases. But that's not, if you see on the clinically lab applying NGS, WGS, none of them are actually applying Nanopore yet because the support system is not there. So that's long-term feasibility, and those all things need to be considered here. I hope I answered your question.
Thanks. Yeah, thanks.
So, Alpana, are there any YouTube questions?
Yes, there are a few questions on YouTube. Mr. Hriday Home Chaudhary has two questions. His first question is, should children and adolescents be able to decide whether the genomic information is shared within the family? And the second question is there any tool available which can extract a gene segment from a whole genome file?
Yeah, for your first question, so, minors are actually not supposed to consent anyway for anything in our life. That's the overall thing. That's the overall concept. But there's a lot of debate. If you ask, should why adolescent, why minor? Why, if we ask, so what about that patient in the NICU? Should they have a say on that? It doesn't really make sense because we consider before 18-year age, we are not capable of making a judgmental decision. So that's the whole concept. Your second question is, yes, absolutely, we do it always. We design virtual panels. Let's say the cardiac disorder we are working on with a particular patient cohort. We probably would not go and look for every other gene in the genome. We design a virtual panel. We just filter out those genes from that panel. As you mentioned, you probably mean that segment of genome, and we just look for those genes, not for the rest of the things. Yeah.
Saurav, one quick question.
Sure.
In following up on Nidhan's question, since you have direct experience, do you think that the error rates on nanopore have fallen to such levels that we can actually reliably use it for diagnosis purposes?
That's an issue. If you look into the paper recently published by Van Ashley, nanopore is the first rapid sequencing. And the question was why they did not actually clearly mention the error rate there. Again, part of I never worked actually nanopore by myself. I always worked on the Illumina side. I always see how the data has been represented. So in our recent NYGC validation, which we call benchmarking, in the benchmarking presentation, I saw there have been run two data and they presented to us. Yes, there is a question, still question for the nanopore, how much the error rate is there.
Okay, so Alpana, any other question?
Yes. So there's another question from Sukanya Mitra, and she wants to know what is the optimum minor allele frequency cutoff for characterizing rare diseases?
I would say it's 0.01%. But again, this is very generalized statement. When we say 0.01%, we use that. Labs do use that. But if you follow the different fields or how we are now actually developing, particularly in the field of cardiomyopathy, we know because low penetrance is a major factor when we talk about those kind of genes, right? If this 0.01% is a very straightforward, maybe applicable to the CBA pediatric disorder, but we have to understand that there's a lot of predisposition genes like the cancer genes like BRCA1, BRCA2, and those are a series of genes we know they increase the risk, and that's also applied to the cardiomyopathy. They increase the risk, they do the predisposition because there are also a lot of low penetrance issues involved. So it's not always easy to put a generalized statement. Instead, the Whitney et al. Paper back in 2018, this is part of NOMAD. If you go to the NOMAD and check the data within the NOMAD, they have certain variables, they reports population max frequency, maximum frequency within like ethnicity, and that calculation gives you, this is basically a variant. Right now, it came to a situation where each and every variant could have a different cutoff based on or each and every gene in that sense have a different cutoff because a lot of different consideration comes in. It's a penetrance issue, it's a prevalence issue of the disease and those kind of things. Yeah, but in general term, for severe pediatric population, we can certainly use 0.01%.
Okay, great. So the next, any other question?
Just one more. So this is from Pragya Lakshmi, and she wants to know when is it that a particular variant in population, when there is a particular variant in the population, what parameters indicate that the variant is not benign?
Okay, so the variant is not benign. I mean, there are three different categories could possible. One is variant of uncertain significance, and variant is likely pathogenic, or variant is pathogenic. As I said, that we apply ACMG criteria to classify them. There are a lot more things actually go into play that if the variant is not benign, right? So variant is uncertain significance is one of the major portion of that classification, where we don't have enough information to call it pathogenic or likely pathogenic or the causal variant. but we believe that that seems not to look like a benign variant either. So it comes to the variant of uncertain significance. Honestly, this variant of uncertain significance, VUS terms have been used for the last 7-8 years. Now, Clinical community and ACMG jointly working towards subcategorize this VUS to leaning towards likely bad, leaning towards likely benign, and solid VUS, something like that. Yeah. So yeah, when you say this not probably doesn't look a benign, probably it would be VUS, probably it would be likely pathogenic. Only you can do that, or you can tell that by doing the classification scoring system.
Great. So are there any other questions?
No, that's it.
Great.
Thank you.
So thank you, Saurav. Thank you once
you.
again. I mean, it was really great listening to you. And again, as I said, I reiterate, we hope that we will be able to hear you in person in NIBMG when you are next in, so people can interact with you directly. And thank you so much for taking time off and giving this talk.
Yeah,
thank you very much.
Yeah,
Stay well. Bye-bye.
Thank you. Thank you, Bertha. Bye.
Thank you.